Hi there, welcome to our pharmacy revision series by CBH Education. Today we're going to be talking about situations that you may face with antibiotics in OSCEs, your pre-reg exam and practice. So the first case study is about you working as a GP practice pharmacist. A patient's about to be issued nitrofurantoin and they have an eGFR of less than 30 mL per minute. In this situation, what do you do? So you're presented with the medication summary. They've been previously prescribed trimethoprim. So how do you deal with this situation? Okay, so the first thing is when you're looking at antibiotics, are we prescribing the antibiotic appropriately? So from the antimicrobial lectures, antimicrobial stewardship, that's obviously been embedded into the MPharm course and in practice as well, and even across CCGs, are we prescribing the right thing? Is the prescribing evidence-based? What do we need to do here? So obviously the first thing is the patient. There's been nothing of a urine MCS in here. So the first thing you need to do is a urine microbiology sample, see what antibiotic it's sensitive to. The next thing then would also be looking at your prescribing, the rationale prescribing, not to apportion blame to a practitioner, but really understand kind of the root cause. Okay, nitrofurantoin, it says it in the guidance. Have you got systems in place to review the eGFR? Does it come up as a flash screen? How are you going to modify your procedures? And that's something you discuss in your clinical meetings to share the feedback as well. So in GP practices, you'll have either clinical governance meeting, significant event meeting, and this is what brings up this knowledge as well, because as GP practices evolve, prescribing becomes more complex. You will be prescribing medication that's unlicensed, medication under shared care agreements, and even medications for it as a temporary measure as well to help alleviate patients' conditions and obviously identify treatment gaps for them as well. And this is what you'll come across in your polypharmacy reviews, which we'll cover in a later lecture. Next one. Patient CJ presents into the pharmacy for advice. They have presented with joint pain. They're on ciprofloxacin as a standby antibiotic. And obviously this is a new treatment regime for the patient. What do you do in this situation? So obviously you've got the medication history again. You've also got the patients on catheters and the trimethoprim prophylaxis is discontinued. So in this situation, you would need to refer back to the prescriber, joint pain, and they need to be prescribed something more appropriate. So obviously, sometimes patients do have urine infections. They're on catheters as well. And obviously, they're on different treatment regimes of the antibiotics. And some will have it as prophylaxis. Some will just have it as a standby as well. And one of the key things here and the key messages is to monitor the usage. So the next scenario is patient AJ is 32, taking no other medication, no other medical conditions. They've been prescribed fluvoxetine for 7 days, 1 gram. It's for cellulitis. So how many 500 milligram capsules are needed in the counselling advice? It's kind of a common question you get really. And what you do here is obviously you'll calculate the amount of 500 milligram fluvoxetine capsules. So they're taking 4 times a day. That's 8. 8 times 7 is 56. Then obviously the counselling advice is just what you'd see on the label really, so spacing the dose evenly throughout the day, obviously complete the course unless they are told to stop, taking the medicine when the stomach is empty, and also this means an hour before or 2 hours after food. Another key thing as well is asking about penicillin allergy. It's really, really worthwhile in any case study to get into the habit of asking allergies. Allergies is absolutely key because the thing is, by asking an allergy, you could be potentially saving a life, potentially avoiding a hospital admission as well. Something which is really, really key because obviously with adverse drug reactions, there are many patients that are treated for that in hospital. And if we can just avoid it by doing the groundwork of asking for allergies, that will even put you good stead in your OSCEs, in your practice, and even in your exams as well. Next, you may get a question that asks you about how to prepare a solution from the SPC, and this is something that we're going to cover in our calculation revision series. So you're working as a pharmacist on a ward, and the nurse calls you to ask how to prepare the vancomycin student, and you advise the nurse on how you would constitute it. So this is from section 6.6, special precautions for disposing and other handling, the preparation of the solution. So basically here you add 20 ml of water for injection to a 1 gram vial, and the vials reconstituted in this manner will give a solution of 50 milligrams per ml. We will bring calculation solutions into this as well, looking at how you would work out the calculation and dilution calculations, which we will cover in our calculations revision series as well. So this is a case study that you will come across quite a lot in clinical practice. You're a pharmacist dealing with a prescription request for a third course of steroids and antibiotics for a rescue pack in over 3 weeks. Before you send this for signing to the GP, you ring the patient. They are breathless and still wheezing. They have been using the treatment with no effect and yet to submit a sputum sample. The patient describes the phlegm as a yellow colour and they state they have no temperature. So obviously what's really key here is that you're bridging knowledge. So your OTC knowledge, you're looking at red flags and what is the patient taking. So the patient is taking Trilogy, salbutamol, MRC scale 3. Now, how would you handle this in practice? So obviously, third course of antibiotics, no sputum sample, yellow coloured phlegm. So key bit of information here is that this is a third course of antibiotics in 3 weeks. So the first thing that you would do is obviously you would get advice from the GP in terms of how to manage it clinically, which they will be more than happy to help you with. And as you're developing yourself in your pre-reg year, and especially if you're working in GP practice, you're going to become more hands-on with patient care. Okay, you're going to be seeing more things in terms of diagnostics. You're going to be seeing more things in terms of testing. You're going to be seeing more things in terms of monitoring. And bridging all this knowledge together actually makes you a more centered pharmacist in playing a role in frontline care, because you're not just going to be dispensing the medication and handing it and giving the counseling advice. In this situation, you're going to be auditing, you're going to be making sure that the right things are prescribed, and also counseling on the use of the medication as well. So what issues have we got here? So auditing the antibiotics is key. So the third antibiotics, they need to bring the sputum sample in, because it may be that the antibiotics that is issued in the rescue pack, so in this case it was doxycycline and prednisolone, was actually the organism was actually resistant. So the patient was prescribed ciprofloxacin, and a pharmacist intervention in this case study made actually avoided a hospital admission because the patient got better. The next pharmacist led intervention was a COPD review with the inhalers. The patient wasn't using the inhaler correctly. So from here, they were using more the salbutamol, and the common case that you see outside the scope of the use of antibiotics is, especially with respiratory infections or managing respiratory conditions, is patients don't use their inhalers correctly. So this patient was taking Trilogy, they were changed to Trimbo, and they were given the spacer device with it, and actually it improved obviously in managing their symptoms. So something that's really, really key here. Okay, so you obviously review the period they've had the antibiotics, review what other courses they've had as well. Okay, we try and reduce antibiotic resistance. Sometimes patients will have clinic letters from the respiratory clinic and the respiratory team on specific management because they're resistant to certain antibiotics as well. And are they under the community respiratory team? Because the thing is, it's all about bridging your contacts. And one of the things is that you have there's a notion and there's obviously guidance around how we integrate care, and one of the things is you've got PCN networks coming into the fray of pharmacists taking an active approach in managing patient care as well, and clinics, and working with secondary care and working with other primary care providers to ensure that we're dealing with things in a much more succinct manner. So one of the aspects here is looking through those clinic letters, and especially if you're in a GP practice, your docman, or if you're on system one, looking through those letters and analysing what treatment options are there for the patient as well. But for this one, it was a sputum sample and ciprofloxacin. Okay. So patient AJ has been recently diagnosed with tuberculosis. They're taking the 4 medications in the initial phase, so the ethambutol, isoniazid, pyrazidamide, and rifampicin. The patient has been complaining of side effects, more specifically visual disturbances. Which drug is this associated with? So basically, it's a best answer question from a pre-reg exam, ethambutol. Right, the next set of questions just focus on selecting the best antibiotic. So Mr. GS has been prescribed a medication for a urinary tract infection and is taking methotrexate. Which antibiotic should not be co-prescribed with this? Trimethoprim. Mr. FB is 39 and has been diagnosed with an upper respiratory tract infection and is allergic to penicillin. Which medication should be prescribed? So obviously, if you're penicillin allergic, you need to look in your COPD guidance. So most places will have a local COPD guidance or managing or an antibiotic guidance in terms of managing patients as well. So the answer was doxycycline. and Mr. AJ has been prescribed an antibiotic and developed knee pain. This antibiotic, obviously, if you develop any form of joint pain, was ciprofloxacin. Now, with antibiotics, you've really got to understand the counseling advice. You've got to understand where they work as well. So, in terms of the mechanism of action. And another thing is also the side effect profile with antibiotics. And one thing I need to reiterate here, which is clear, especially with tuberculosis as well, you do get asked this quite regularly, and it sometimes can present in clinical practice as well. When you're doing your medication histories as well, it's also important to link if they are taking inhalers, so if they're taking any form of inhaler, are they on any form of rescue antibiotics? If patients have catheters, it's also worth looking, have they had UTIs? Do they have any management of antibiotics either on standby, or are they on any prophylactic antibiotics as well? And it's also worth looking, are patients have any allergies to antibiotics? Because this forms one of the big key things of hospital admissions, something like penicillin allergies or any general antibiotic allergies as well. Thank you very much for listening to this presentation by CBH Education in our pharmacy revision series. For more presentations on OTC conditions, OTC medications, pharmacology, understanding more about OSCEs and the different types of drugs and counseling advice, please follow us on our Facebook, Instagram, and YouTube channel.